Good afternoon, everyone, and a warm welcome from Pretoria Centurion, to be specific. We have an absolute full house here this afternoon. Last when I checked, we had 1,073 registrations, and I literally hope each and every one of you can get a seat to join us. I'll give it about 2 minutes to settle in. Today is our 19th webinar in our series of webinars, and I'm very honored to have 3 guest speakers with us this afternoon. I will introduce them all in just a minute. But I can let you know that we've got 20 disciplines joining us this afternoon. The newest addition is actually a dental technician. But we do have 234 psychologists. We've got just over 300 physiotherapists. We've got 80 occupational therapists, 136 bios. We've got 51 speech therapists and audiologists, 34 dietitians. There are 32 podiatrists, 27 medical orthotists and prosthetists. We've got about 10 social workers, 6 chiropractors, and 36 optometrists. We've got 15 doctors joining us this afternoon as well. And then we've got a handful of nurses, phytotherapists, art therapists, hearing aid acousticians, and registered counselors. Hopefully load shedding won't affect any of us this afternoon, fingers crossed. But if you do lose connectivity, and I think we lost Zola there for a minute because of this, the webinar, as well as all our previous webinars, are available to watch on our social media platforms, which includes our website, which is called easymed.solutions. You can see it on the screen there. There is also the YouTube clip, there's podcasts, and Spotify. If you give me a second, I'm actually just going to copy all those links, and I'm going to paste it for you in the chat functionality. Let me get it to all attendees. And you should see it there. You can easily just copy and paste straight from there. Now, my name, as you know, is Lani Uys, and I will be your host again this afternoon. I'm also a product manager at the SpaceNet Global Group, who is kindly sponsoring this afternoon's webinar again. I think in the bottom left-hand corner of your screens, you're going to see a very familiar face, Dr. Kwinda. And we've had some interesting conversations with Dr. Kwinda before around ethics. I think we had 2 sessions, both of them available on our social media platforms. Now, Dr. Kwinda is the acting HPCSA Registrar, CEO, and the HPCSA's Ombudsman. He's also a qualified family physician. He's a 3rd level LLB student and an ordained and very active pastor in the ministry. Now, Dr. Kwinda contacted Deon and myself about a week ago, requesting to use the EasyMed webinar platform to address you, the healthcare providers and members of the HPCSA, regarding pressing matters of forensic reviews, audits, biomedical schemes, and the role of the regulator or regulators in this space. Dr. Kwinda, welcome back, and thank you for choosing.
Thank you, Lani.
Thank you. Thank you very much for choosing the EasyMed webinar platform, who is a leading practice management system that is not only intelligent, but mobile and very, very easy to use. Welcome, and it's nice to have you with us again today.
Thank you, Lani.
A new guest speaker joining us this afternoon is Zola Dantile. What an honor having you here, Zola. Zola has a master's degree in physiotherapist. She was the vice president of the World Confederation of Physical Therapy. She's the past president of South African Society of Physiotherapy, the SASP. She's the outgoing chairperson of the Physiotherapy, Podiatry and Biokinetics Board and a council member of the HPCSA. Now, if that's not enough, ladies and gentlemen, she still runs her own private practice, and she's a part-time lecturer at the University of Pretoria at the physiotherapy department. So, is there anything you don't do?
Yes, I don't run.
Good for you. Good for you. Welcome. Thank you so much for joining Thursday webinar with EasyMed. And last but not least, my colleague and my dear friend Deon Buhrs. I don't think Deon needs much introduction. I met Deon, we were both in our 2nd year at university, but 1st year physiotherapy. Now he is the director of ProfNet Medical. He's the original brains behind EasyMed, the practice management system, and he's part of the SpaceNet Global Group Executive for Operations. Deon, welcome, and thank you again for making yourself available.
Thanks, Lani, and afternoon, Zola and Dr. Kwinda. Nice to have you guys here.
Thank you, Deon.
Excellent, excellent. I do feel there's 3 physios on the panel. We perhaps need to ask for some other hands and other disciplines to come and join us. Guys, don't be shy. Contact us if you want to join us. Anytime, we don't bite. Ladies and gentlemen, we've got a full schedule this afternoon. There's a lot that we need to talk about. We did ask for some of your questions before the registration took place or during the registration period. We're going to try and get to as many of them as possible. If you do have a burning question, please use either the chat or the Q&A functionality. I'm going to try and keep an eye on both of those platforms. But I think we need to get started. And Dr. Kwinda, I'm going to start by looking at you. I think you moved to the bottom right of the screen now. Can you perhaps share some of the statistics with you with regards to some of the forensic cases which has been logged with the HPCSA over the past 2 years, sort of the financial 2019-2020 here?
Thank you, Lani, and good afternoon to the fellow panel members and also practitioners who are in attendance to this very important webinar. From the stats that we have, and really specifically, Lani, concerning matters referred to us for frauds, and this is from the medical schemes, but in terms of all the complaints that we receive, we categorize the nature of complaints into different categories, fraud being one of them. One would say the highest nature of complaints that we sit with as the HPCSA is related to negligence, sitting at 29%, and that is followed by matters related to accounts at 13%, and matters related to medical reports at 7%. Then fraud is the 4th nature of complaints that we are dealing with as a regulator, sitting at around 6%. Now, there was a question where somebody asked, what are the common complaints that are lodged against psychologists? And I can tell you that most of them are related to reports, and some are also related to unacceptable relationships with clients, where most of the times you find that the relationship goes beyond the professional relationship. I remember last week I had a contact mediation of a matter like that, where a psychologist who was involved with a couple that has divorced was end up going to the house of the ex-wife. So the husband was worried about the relationship because they were having separate sessions in the interest of the children, but there was another relationship now where the psychologist was going to the home and the kids were reporting that he comes to the house. So those are some of the issues that we have seen in the psychology profession. Now, when you zoom in and look at the medical schemes, maybe let me start with total number of cases we received last year were 155. That is the 2019-2020 financial year. And if you were to go by the schemes, very interesting, and I think this is very important. Out of the 155, you can guess which one is the highest that is reporting to the HPCSA, and you will be wrong because I know people will think of, I won't mention the name, but let me just tell you that the highest out of the 155 is coming from MedScheme, with 56 cases reported by MedScheme, followed by GEMS at 50, followed by Discovery at 19, followed by Bonitas at 17, then Genesis and MediHelp comes at 10. Then you've got Genesis, Platinum Health, and Alliance MidMed with one complaint each. And when you zoom now into the boards, now this is where I speak to you as professionals. Of course, I'm not going to deal with this according to the numbers, because what is critical is to look at the proportion against our register. I mean, Medical and Dental Professions Board has got the highest number of practitioners compared to all the other boards. But it will be interesting to know that Of course, they are highest in terms of numbers, followed by psychology, followed by speech, language, and hearing professions. But let's talk about in terms of proportion, because that is what will tell us against the register which profession is leading as far as fraud is concerned. So we look at the number of complaints received in that particular profession or board against the number of practitioners on the register. And what we have is that the Speech, Language, and Hearing Professions Board is leading amongst the 12 professional boards in terms of fraud. Followed by who? Followed by the Dietetics and Nutrition Board, and then followed by Optometry and Dispensing Opticians Board. So in terms of proportion, SLH, speech language, is at 0.5, Dietetics and Nutrition Board at 0.4, Optometrists and Dispensing Opticians Board at 0.3, followed by Psychologists at 0.20. Then comes the Occupational Therapy Board at 0.1. So Occupational Therapy and Medical and Dental Professions Board are both at 0.1. The rest are less than 0.1. And one can say physiotherapist is 0.05, radiography and clinical technologies at 0.04, and then your dental therapists at 0.08. So you can see when you look at the proportion against our register, the smallest board is leading, because Speech, Language, and Hearing Professions and also the Dietetics Board is leading. And let me conclude, Lani, by saying that our experience, of course, is that our small boards like Speech, Language, and Hearing and Dietetics Board, almost 60% of their cases in preliminary committees of inquiry is related to fraud. So I think it's very important for us to be aware of this as professionals, that as much as we have got problems in this particular space, we do have colleagues who are being fraudulent, and that is the reality. Thank you.
Absolutely. Thank you very much. I think everyone really appreciated you sharing some real stats with them. There's a lot of questions around that. So hopefully that answered some of the initial questions. Zola, perhaps just looking in your direction, and I see your mic is on mute. You are, like you said, you are the outgoing chairperson of the Physiopodiatry and Biokinetics Board. And I'm sure you are aware of these stats, but are you surprised with the stats? Because we know there are thousands of physiotherapists and podiatrists and biokineticians, maybe less bios, or podiatrists rather. But seeing that that board is actually not on top of the list, does that come as a surprise to you?
Thank you, Lani, and good afternoon to the participants and the practitioners. The surprise, yes, because when you look at the board, because of the three professions, we've got physiotherapy, podiatry, and biokineticists, you always find that the physiotherapists, they actually come on top. Their cases are far more than the podiatrists and the biokineticists. So, but when you look now, Dr. Kwinda has given us the total picture that actually, I mean, like in all, the speech and language are the leading ones in the whole council, all right? But we do get a lot of cases in the board. It will be the physiotherapists that are the leading cases. The interesting part with the physiotherapy cases that gets reported, it is related, in private practice, it will be related to billing. In public sector, it will be related to negligence. So, I mean, you actually find that difference, because the private practitioners, they do their own billing. We can talk about whether it is erroneously, and who reports the billing. It's either the patients that they say that this physio was with me for 5 minutes, but the bill came too high for what the physio would have done. Or the medical aids, they actually say that you are an outlier. I guess that's a discussion for another time.
Sure, no, absolutely. Thank you.
Yes.
Dr. Kwinda, thank you for answering a question in the chat functionality. I just want to draw everyone's attention to the question. It was to Dr. Kwinda. Was the cases confirmed fraud, or was it still being investigated? And you kindly answered that these cases are being investigated. Am I correct when I'm saying that? Perfect.
That's correct.
And there's another question that came up, and it's the board that you had right on top of your list, speech therapy. And the question was, can you separate speech therapy and audiology? Do you have that stats, or is that not readily available?
We can separate. Of course, what I gave to you really is general information, but we can drill down per profession, like across all the 12 professional boards. As you know, in speech languages, speech therapists and audiologists. In physio, you have got physiotherapists, podiatrists, and biokinetics. We can drill down to that. It's very easy to do so. But for the purpose of this meeting, I just gave a broad one so that I can include everyone. But if you want further details, we can drill down to the minute details.
All right, so it's possible, but for today's purposes, let's just keep it at that then. Something that came to mind is you mentioned where the complaints are coming from, and you mentioned some of the medical schemes. What rates higher? Is it the medical schemes that come and lodge a complaint or a case with the HPCSA? Is it patients, or is it one provider towards another provider?
What really is high in terms of that statistics is that in fact, medical schemes are high in terms of reporting, then followed by members of the public, then followed by other practitioners. Yeah.
Okay.
But the medical schemes are high.
Medical schemes the highest.
Yeah.
Lani, I wonder if I can just pose a question there just for clarity, and that is, Dr. Kwinda, the numbers seem pretty low if one hears the talk on the town really around practices that are being approached by various medical scheme administrators relating to suspected fraud or outlier status. Would you say that we should in fact be encouraging those schemes to rather be bringing these cases to the HPCSA? Because there seems to be quite a gap between the experience on the ground of direct complaints that are brought to the practitioner by the schemes versus those that go via the HPCSA.
Yeah, Deon, I mean, one of the reasons why we are here this afternoon is because, you know, when I was asked to engage with Discovery, because practitioners are really crying because of but you look at what Discovery is reporting, is quite very low. And you may have a situation where the schemes may be opting to deal with the matters themselves rather than coming to the HPCSA. And this also takes me to the Medical Schemes Amendment Bill. If some of you have bothered to read it, you will have realized that they've opened an avenue where now anyone can report to the Registrar of the Council for Medical Schemes on any matter that are within the ambit of that particular act. And it may just be telling you that there may be a shift. If that act is enacted the way it is in the bill, you may find that they may not even come to us, but opt to go to the Council for Medical Schemes. So it really, the issue is you may find that the schemes do not want to come to the HPCSA for whatever reason, and they try to deal with matters themselves and only come to the HPCSA when they think now they can come to us. One of our experiences, which has really affected our approach in terms of investigations of cases of fraud, is that by the time we go to the practitioner is not there anymore. They have closed shops, and you find that they say, no, this person was practicing here 2 years ago, and they have left. And when you call the practitioner, they say, hey, the scheme was on my case. I could not continue running my business, so I had to close my business. So those are some of the realities that are on the ground.
Yeah. So I mean, I guess the current scenario is really that we're experiencing is that practitioners and medical schemes are having these discussions, and they're happening sometimes even behind closed doors, and sometimes even being encouraged to be had without lawyers present and so on. While at the same time we've got the two regulatory bodies, the Council for Medical Schemes and the HPCSA, that are very often not involved in any of these conversations or attempts to resolve these cases. Are you saying we should be bringing those regulators in, more involved? I guess there's some practitioners that say, I'm not very happy with the way that I've been dealt with or handled by a medical scheme. Would they have the avenue to report that, for example, to the Council for Medical Schemes if they had concerns in that regard?
You know, the reality is that the regulators have been spectators for a long time, while the practitioners and the medical schemes are playing the game. And it's a high time that the regulators also come on board and participate in this game. And as the HPCSA, there are mechanisms that we have started to put in place, of course. Colleagues will remember that some of you will refer matters to us where you feel that, but counsel, are you just quiet while I'm being bullied this way when I've not done anything? And payments have been stopped and all those kind of things. And most of the times we have been referring practitioners to report the schemes to the Council for Medical Schemes. And we have started engagements with the medical schemes recently, which are continuing, including the Council for Medical Schemes, you know, as another regulator for the schemes, to say we need to be involved here to such an extent that because now we have developed a unit, which I think practitioners need to appreciate this from the HPCSA. For a long time, we have been viewed to be, you know, prosecutors of practitioners with very little guidance that we provide. With our turnaround strategy that we are implementing now, we established the unit that I've informed you about before, professional practice, which is a division headed by Mr. Mbodi now, that will play a very significant role in terms of practice matters, because what we are talking about here are practice matters. We all know coding related issues are the ones which are bringing us here today to have this kind of a discussion. So we are at a place where we are saying practitioners can approach us when they feel that they are not really fraudsters and they want assistance from the regulator. I mean, we have had discussions with the schemes who have admitted, including Discovery, that sometimes we know we could be in error and we do not mind to review any matter that is brought to our attention. And we thought maybe as a regulator, we can say to practitioners registered with us, you can approach us through professional practice, and then we will contact the scheme and say, we have got Deon, a physiotherapist, who is saying that you guys are harassing him, whereas he is doing things according to book. And they say, we are willing to review and give you a report of what we have as a scheme. And we went further and said, then if we receive a report, and I think this is one thing that practitioners need to understand, is that if the report of that review really reveals prima facie evidence of fraud on you as a practitioner, the efforts that we are putting in assisting our practitioners, if we pick up that indeed you are fraudulent, then we are simply going to hand over that matter to complaints handling and investigation and open a case of unprofessional conduct against you. But if the scheme is the one that is on the wrong, and this is where, you know, what we have also started to engage the Council for Medical Scheme, which is a discussion that is ongoing, is that we will refer that matter to the Council for Medical Schemes. And that does not prevent practitioners to report a scheme to the Council for Medical Schemes. And it also does not prevent a scheme to report a practitioner directly to us. But we are saying, as a regulator, if a practitioner feels that they are being unfairly treated, then they can approach us and we will inquire with that particular scheme. One has been in this game for a long time as Ombudsman. I have had cases where the schemes have paid patients that they did not want to pay by just me as an Ombudsman asking a simple question, why did you not pay? And they say, no, we are going to pay, and they pay. And the matter is closed. So they are very much open to engagement. And with the current discussions, that I have personally had with them, they have shown interest to engage where there are allegations that they are treating practitioners unfairly. So that is a system that we are putting in place. Of course, we have not tested it in terms of the turnaround time to get that information and all those kind of things, but we believe it's a step to a better direction that we can only refine as we go along. Thank you, Deon.
Sure. Zola?
Yes. Okay, thank you. Just to follow up on what Dr. Kwinda has said, because we actually are sitting as a board, as I left the office the 31st of August, I am sitting with cases of physios that dates back to 2016 that have been clawed back by the medical aids. So, Dr. Kwinda, if I understood you properly, you are saying that if those practitioners feel aggrieved that the medical aid was unfair towards treating them and forced them to sign when they had done nothing wrong, you are saying that they can come to the Professional Practice Division of the Health Professions Council or to the Ombudsman to say, I feel that I did everything by the book, but the medical aid still wanted me to pay, and they actually clawed back. Because some of the cases is that the physios are saying the medical aid even suggests to you that this is the code that you should have used instead of this one, whereas they were not in front of the patient. So they were not involved in treatment, but they suggest codes that needs to be used. So, I mean, those are some of the practices that we are left on the desk for the incoming board to deal with. Thank you. Thank you.
Okay, Zola, it's true what we are saying. Of course, not Ombudsman. I don't want my office to be that much involved in this one. We
clarify.
When we established this professional practice at HPCSA email, my office was responsible for all these queries. And now that we have got a division, is that division, of course, the expertise in my office will assist the division where there's lack of capacity. We will assist, but that unit is going to be responsible for that. Really, we are willing to go into that, and that is where, if indeed a practitioner was treated unfairly, that is where we can report the matter to the Council for Medical Schemes. We do not know how they deal with matters on their side, but if really the matter was not reported to us and we pick up that there's unprofessional conduct, we'll also deal with it. And there's a question also there. So in simple terms, Zola, is that those matters can still be brought to us and we can refer them to the schemes and say, can you review these matters? Somebody asked a question, what is the turnaround time for complaint at HPCSA? It depends where your matter is being dealt with. If your matter is being dealt with in the Ombudsman's office, our turnaround time is 90 days, but I can tell you, currently my office is finalizing matters within 40 days. So that is how efficient we have become. So within 40 days, we are done with the complaint. Either we close it or we refer it for preliminary investigation. But when it goes to the board, because there are two processes involved, at a preliminary inquiry process, it can take up to 8 months, meaning that the investigation process, because it also involves, by the way, you being given 40 days to respond to the complaint before it can go and serve before the committee. So maximum is 8 months, although there are matters. So within 8 months is finalized at preliminary inquiry. And any matter that goes to a full inquiry, it can take up to 18 months if the matter is finalized at a full inquiry. So those are the timelines in terms of our complaints. So in the Ombudsman, within 90 days, now we are sitting at less than 50 days, we are finalizing complaints. Preliminary inquiry process, 8 months. If it goes to full inquiry, it can go up to 18 months. Thank you.
Thanks, Dr. Kwinda. I think that's really valuable. And I think just talking about turnaround times, perhaps this is coincidental, but you did mention earlier that you had met with Discovery. We've even had reports of people saying that even after that meeting, there was a sudden change in tone. So I think the turnaround times can be even quicker in days, I think, when the right people are talking to the right people. Is there anything that you want to share relating to that engagement that would give us some sort of visibility or understanding of the views between HPCSA and Discovery specifically?
Deon, there was a problem. I didn't hear you clearly.
Okay. My question just is, you mentioned earlier that you had a meeting with Discovery, and we've seen already some changes in approach or tone that some people are reporting. So I think sometimes the turnaround times can be a bit quicker when the right people are talking to the right people. Is there anything relating to that engagement that you feel would be valuable to share as far as our understanding of Discovery specifically and the approach on suspected fraudulent cases?
Yeah, Deon, I had to change the connection here because it was showing me that the network is unstable, so I missed everything. I'm sorry about that.
I'll make it short. Is there anything you want to share? Yeah, just around Discovery, your meeting with them. I think that's been quite a valuable meeting. Is there anything you want to share with us relating to that?
Okay. I think really a quick one on that in terms of what transpired in the meeting, and touched on that before, was that, of course, they are concerned about the kind of advices that practitioners receive, especially legal advice, where on their side, although they may want to engage with the practitioner cordially, but practitioners seems to be getting advices which sometimes are not correct advices. And number two, they do acknowledge that they also on their side, they do err in their approach, and hence they are open to engagement where there is a view that they are not doing things right or they are being unfair. And of course, one thing that I think all of us do know is that the schemes or the administrators are really interested in getting that money back into the coffers of their members if the money has been taken fraudulently from the scheme. And that is where, the few numbers that we spoke about earlier make us understand that indeed there are those who are being fraudulent, because we have had cases of practitioners who were found guilty of fraud and they accepted the guilty finding. So we do have people who are fraudulent. So they are saying, unfortunately, the challenge is that, of course, the HPCSA to a certain extent, we also do not help them to recover the money. And hence they find their own way of going after practitioners. And we know they are also supposed to go to the law enforcement agencies in terms of Section 34 of the Prevention of Corrupt and Combating of Corrupt Activities Act. But the courts will not also assist them to get the money. So hence, targeting you as practitioners with all those threats and bullying to get you to sign something for them to get the money back end up being the method that they use, because it seems we are also not helpful in that particular instance. But what I liked about the outcome of that meeting really was the willingness to engage and the availability to engage. And that's why I'm saying this is really work in progress, which I'm very much positive about, where we are still going to have an engagement with them as the regulator and see the best way so that we can have even contacts in all the schemes or all the administrators, where if you bring your matter to us, and this also includes BHF. I've also spoken to BHF, Dr. Hlelin Tlapo, the head of the HFMU unit there, and they are willing to say, no, we are willing to facilitate the process if there are practitioners who feel that they are being unfairly treated. Sure. So for me, it's looking positive. And at the same time, we are also engaging with the Council for Medical Schemes.
Dr. Kwinda, I think a hot topic. Sorry, Zola, do you want to go first on this? I think.
Maybe, yes, before I actually forget it, I actually wanted to say that part of the bullying that is unacceptable from a health professions council point of view is the request by the medical schemes of clinical notes, and that the practitioners easily give the clinical notes in the restlessness when they are being bullied. And under no circumstances may any practitioner give the medical scheme the clinical notes. Should they then find that they are requested clinical notes, I think that is the time to quickly run to the Health Professions Council to say, listen, these guys are now wanting the clinical notes and they do not have the consent from the patient to give clinical notes. That is the only time that they may give, the times that they may give out clinical notes, the practitioners, is when there is a court order. Number two, when the patient has consented. And number three, according to the Health Professions Act, when it is in the public interest that you actually do so. But any other time, you may not give clinical notes. So I actually, am I aware that, I am aware that practitioners have given out clinical notes to Discovery under some little dodgy things. I actually needed to actually mention that. Part of the bullying, as part of the bullying, yes.
Yeah. Maybe on that one, Zola, what you forgot to mention is if there's a statutory provision that requires disclosure of confidential information, that is, and basically, this is the issue of disclosure of confidential information, as the clinical notes, of course, what is contained there is confidential between a practitioner and a patient. And we have sought legal opinion, and there are different opinions on that, of course, because in terms of the provisions of the regulations, a scheme can request information kept by a healthcare provider or even a managed healthcare organization pertaining to their member. And that has to do with the contracting between the scheme and the member, where the scheme can have access to the clinical records kept by health practitioners. And that has been the legal interpretation from the HPCSA. But I think what assists also here is that if practitioners can approach the HPCSA, then they can also be assisted in going about doing that in a way that patients' confidentiality is not going to be compromised.
Yeah, thank you for that, Dr. Kwinda. I just wanted to come back to the previous point that you made, that the engagements between the regulator, HPCSA, and various medical schemes and administrators is a work in progress. You also asked that some of these concerns that you've heard will be raised with the schemes, the relevant schemes, in your continued engagement. We've obviously heard a lot of concerns being raised by various disciplines in how they're being handled, right from the bullying tactics to being almost forced to sign acknowledgements of debt under duress and so on. Would it be worthwhile that we actually group together some of these concerns that have been raised and forward that through to the Health Professions Council to assist you in those engagements with the various medical schemes, so that you have it straight from the providers? Can we coordinate something like that?
Deon, we will really welcome that, and that will assist us to at least have a direction when we have got information in front of us. So if you can facilitate that, we will really appreciate to have that.
All right. And we can direct that to yourself?
Yes.
Okay, fantastic.
Yes.
We'll do that. So anybody listening, I think we'll put up some details afterwards, and we will reach out. I think we have received many people raising concerns, and we'd be happy to do that and facilitate that process. Thank you, Dr. Kwinda.
Yes, one of the things I actually need to say is that as a board, when I exited, we actually looked at the coding structure, and it is definitely antique. It needs some shaping up. It needs some interrogation so that it is in line with the current scope of practice that we have submitted for promulgation. Once the new scope of practice has been promulgated, then we actually would need to relook at the current codes, the coding structure and the tariff structure as it is currently being used. I don't know how we are going to school the medical aids, but we will endeavor to school the practitioners that are registered. But the medical aids, definitely, they would actually need to shape up, because they seem to think that they are the custodians of the tariffs, and they are not the custodian. So those tensions, I know the Department of Health is actually also the custodian. We will actually have to advise the Department of Health. The boards would have to advise the Department of Health of the current structure once they approve the scope of practice, so that it begins a process of ensuring that it is talking to the current practice that is happening. I'll give an example that at university, all the physios, they do it in their practice, that whenever you are treating a patient, you do a reassessment as you treat, when you treat, at every given point in time. And when the patient comes again for the next follow-up session, you still do a reassessment. But the medical aids, they actually say that they only, according to the current tariff structure, you are only paid once throughout the care period. I don't know what the care period is determined by the particular medical aid. So you actually can tell that there is a problem right there. That what you practice, you were taught, you are trained to do, and what the scheme is willing to pay, and what the tariff says, they're talking in opposite directions. So that's one example. That's why I'm saying that the tariffs causes a lot of tensions, because the practitioners, they don't use the codes incorrectly. They're using them according to how they are trained. And they're not intending to be fraudulent, but then the rules of the tariffs, they're not talking to the current training. So, I mean, those are the tensions that we actually need to be corrected going henceforth.
Yeah. How do you suggest that gets handled? I mean, is that something that's handled by the associations and societies? Is the HPCSA going to get more involved in tariffs and setting of code structures? Because right now we don't really have a formalized forum in which these amendments or updates can be done, other than individual engagements with various schemes, which actually creates more complexity than cohesion.
The HPCSA would actually need to be involved, definitely from a regulatory point of view, to ensure that they regulate the practice, and they ensure that it is in line with the scope of practice as well as with the minimum standards, that the tariff structure covers the whole range of practice into the future. Because what is happening with the current structure, it is kind of filling in the potholes. When there is a new equipment that comes, then there needs to be a scramble of what kind of coding should we actually use. So there's not a comprehensive way of looking at it. So definitely the Health Professions Council, I would actually think that they would need to be the drivers of this one and actually invite all the stakeholders. If the profession wants to do it, because the profession has been doing it, but in bits and pieces, like the pothole kind of fixing, the pothole kind of scenario. Yeah. Sorry to use that analogy.
If it makes sense to all of us in South Africa, especially.
Lani, I think you wanted to say something, or can
I? No, I just wanted to delve a little bit deeper into the coding. And very often, if a practice does get audited by an administrator or a medical scheme, there's a clear difference between fraud and wastage. Fraud being there's malicious intent, you're trying to steal money from the administrator or the patients or the medical scheme, versus waste, which is potentially, and I'm just using it as an example, incorrect coding. You might be charging 3 procedure codes, we only allow 2, or 4 procedure codes, we only allow 3. How much does the society or the association try and support providers who are being audited when it comes to wastage or incorrect coding?
I don't think you are asking me. I'm the regulator.
I am asking you.
No. But from the reports I've heard, from the practitioners that actually reported, they actually say that they actually get advised by the Society of Physiotherapy to contact lawyers. And there's apparently some lawyers that are the preferred providers for the society. I don't want to get into that because I'm not too clear on the detail, but I am aware that the society would actually then advise them to actually go and consult with those lawyers so that they can actually be able to come around with that. And I think the discussion here is saying that there's an alternative. Once you actually are finding you don't find joy, and you don't like the way the medical scheme is talking to you, tone, you go to the Health Professions Council. We want the Health Professions Council to be the go-to, because we are the custodian of your scope of practice. Mm. The custodian of the scope of practice. They are the ones, they're not the custodian of the codes, as we are saying, but we now, in our previous meetings, the last meetings, I think, as the practice committee of the board, we looked into the tariffs, and we actually could see that the big gaps in the tariffs that actually needs to be filled, because they are not talking to the current practice. They were done, I don't know, and then there's just been this patchwork that has been continuously being done. So the codes, people have not been, practitioners have not been coming to the board to ask for assistance, because if they would come to the board, we would actually be able to see whether there's any unethical practice that is smelling or unprofessional behavior that is unbecoming. So they've actually not been coming at all. They've absolutely not been coming at all, for reasons that I don't like to go to here, because I'm not too clear on the reasons. But I've got a sense of the reasons as to why they were blocked, to say the least. There was some blockage. And also what deterred them is the fact that Dr. Kwinda mentioned earlier on that we were sleeping, the board were sleeping, and they were waiting, and they were not proactive in guiding the profession. So now there's a turnaround. We've been given a window of opportunity to turn around the wheel, to say, let us guide the profession, let us be proactive, let's not wait for things to get too bad, and let us be proactive and try and assist and guide.
Yeah, I think it is very exciting to see the changes in the intent, and I think that the proof's in the pudding. I think many practitioners are quite excited, and it's just about following that through and making sure that that we put these processes in place. And wherever we can assist, I think that's important, that we all shoulder this and drive it forwards. But I think part of Lani's question there, just relating to often we hear the fraud, waste, and abuse sort of clauses put together. I think the BHF had a conference on that specifically. But around the waste, I think what is important is that while we recognize that not all healthcare practitioners are fraudulent in their intent, and most of us, if not the vast majority of us, are really out there to provide good healthcare to patients and bill for fair remuneration. But I think in that billing for fair remuneration, there are times that practitioners are incorrectly using their coding structures, where there are rules and where there are frameworks around that. Lani's example of only you being able to use 3 codes for a specific condition in some disciplines. And where that's done in error, and there is 4 codes charged, for example, for one condition. I think it's important for practitioners to recognize where they have erred as far as the utilization of the coding structure goes, and understand that schemes can, and Dr. Kwinda, I'd like your opinion on this, but schemes can go and review back up to 3 years. Sometimes they do it even longer than that, to say, over this time, we try to pay you in real time, or as close to real time as we can, and we do that in good faith. But in our reviews of our payments over the last 3 years, we found that this was paid in error. Yes, it was paid in error, but it was because you billed that in error, and there's a correction that needs to be done. So I think that's there is a middle ground to this, where I think sometimes healthcare practitioners need to recognize where they may have erred. But again, to your point, Zola, I think the coding structures need to be a whole lot clearer in many cases to actually ensure that there is equal interpretation of the application of those rules, so that we can really stand on the point that ignorance is an excuse. If you read that, you would understand that, and you would have applied it appropriately. But there is a lot of grey areas in that interpretation still, unfortunately. Dr. Kwinda, are you of the opinion that schemes can in fact go back 3 years and correct on those incorrectly paid accounts?
I mean, what the schemes are doing is based on Section 59 of the Act. And as far as I know, without reading the Act right now, it does not even limit them in terms of how far back they can go. It simply says if there is money paid bona fide to a patient, or but they don't only do this to healthcare providers, but also to patients themselves. Then they can recover that money from the subsequent claims. So it does not tell how far back can they go.
Yeah. Okay. Thank you. Lani?
I think a lot of time the providers, and this is some of the questions that we got in, is the providers are in private practice, they bill, they treat their patients like they usually do, and then 3 years down the line, there's an audit on their practice. And I think a lot of the providers feel, why didn't the administrator or the scheme tell them that they are coding incorrectly? Now, my question is it the scheme's responsibility to tell them, or is it you as healthcare professional? Is it your own responsibility to know your billing rules, guidelines, etc., etc.? Perhaps Zola, or Dr. Kwinda, sorry.
No, it is the practitioner's duty to be fair and have an in-depth knowledge of all the rules that are governing the tariffs. So it cannot be the scheme that is the duty to say you are billing this incorrectly. The scheme, they look after their own interests, and the practitioners need to ensure that, because of the guidelines that are set, to ensure that you have decided to use a tariff, you understand exactly that that particular tariff relates to that particular condition that you actually are dealing with. So it is definitely the duty and the role of the practitioner to know the tariffs, not to be told by the scheme.
Sure, thank you. Talking about roles and duties, there's a question that came up. When it comes to patient consent, whose responsibility is it to get consent from the patient? Is it the healthcare providers, or is it the scheme or the administrators?
You're relating to consent to share clinical notes.
Share clinical notes, yes, Deon.
Yeah, it's an interesting one. I think I'll leave our esteemed guests to answer that question, but I think very often there's reference to say a scheme has already got consent from a practitioner from a patient, when that patient actually joins the medical scheme, that in those terms and conditions, there is consent there that the patient gives to say that the scheme can in fact request those clinical notes from a provider. But that's a very concerning a clause or assumption to make then, that is the legal grounding on which that is pivoted. I'm not a lawyer myself. Dr. Kwinda can again maybe give us some more information on that. But essentially, if you're signing something, I joined my medical scheme 20 years ago. I signed that, and the POPI Act makes it very clear, and 20 years ago they had no visibility of the imminent POPI Act, makes it very clear that when information is shared, it needs to be shared with specific intent and purpose, and for only that purpose, and I need to consent to that if it's my personal information, and that when that sharing of that information has met its required purpose, that information must be returned or removed from that space. So I think it's a very shaky ground to lean just on that. And then I've also had some other people saying that me as a practitioner, if I join a specific network arrangement, that in those terms and conditions of joining that network arrangement between myself and the medical scheme in discussion, that in there I give consent that I will share the clinical notes of the patient. And I'm very concerned about that as well, where the patient doesn't have insight or visibility on the fact that I've consented to share their information with somebody else. So I think those are two concerning elements. Dr. Kwinda?
I think we have spoken about this before, remember, Deon?
Mm-hmm.
Especially this matter that we are talking about now.
Yeah.
And really, what remains is our patients, and I think all of us here who have got schemes, are we made aware of such provisions before we sign, or we are interested because we want a cover just to sign? And it goes back to the issue that really members of the schemes are not well educated. And for me, it is just one of those issues that, with engagement with the other colleagues, including the Council for Medical Schemes, to ensure that some of the information really, members of the public need to be informed about such clauses before they can even join a scheme, because many of them don't even know that there's such a provision. So that is basically the contract between the schemes. And I'm saying this not having looked at those documents that people sign, if that is even included. I'm just interpreting it from the regulations made in terms of the Medical Schemes Act, and where it provides a statutory provision for the medical scheme to have access to the notes or the clinical information kept by a healthcare provider or a managed healthcare organization. So it's just something to explore further, Deon, and see if indeed members of the schemes are aware. Are these brokers making them aware, or brokers are interested in getting that commission every month without providing sufficient information to people to join the scheme.
Yeah, yeah. I'm seeing a tremendous amount of Q&A here, Lani. I don't know if you got some answers, but I think we're going to have to answer many of those after the webinar and actually put them up on the site. There are some very interesting questions there that I do think need some attention.
Yep, or do another webinar if everyone is willing and able to join us again at some point. Yeah. I am also just looking at the time. It is 5 minutes to 5, so we do need to start wrapping up. I am going to give you all time to just give you sort of a last thought, but perhaps, Zola, was there anything else that you wanted to discuss or share with the attendees today?
I wanted to actually say, to encourage the attendees to use the board as whenever they are unsure, to actually be able to access the board with their questions. And I do know that in the past, the things have been sluggish, but there has been significant improvement using technology that we are able to post your questions. And I'm sure as we develop, as the board develops, there are going to be platforms where you can actually be able to drop stuff on site and with the professional practice committee. And I did see somebody saying that the HPCSA is going to be inundated. It's not going to be inundated, it's their job. It's within their mandate to carry out some of this function, some of the functions that we're supposed to carry. Dr. Kwinda rightly said that it has been the mandate of the board to guide the profession. So now it is up to the Health Professions Council and the board to step up to the plate to guide the council. And the good thing is that I would have retired sipping some water, sparkling water at the beach. I won't be there to carry out the work that is coming. But there's lots of lessons that we have actually learned. We have learned during COVID that there's a whole lot of things that are possible without people meeting face to face. The webinars like we have now, you know, we don't have to travel. You are at your office or at your home and you are able to access a whole lot of people. So what I wanted to say is that let us use the HPCSA, let us test the potential and let's make sure that we are guided. And part of the duty of the HPCSA, it is to educate the public. Whilst we're protecting the public is to educate the public. And that has not been done sufficiently well. So it is the practitioners that are going to be driving the boards to ensure that they can fulfill their mandate. Thank you.
Perhaps, Dr. Kwinda, before I come to you for a closing thought, I'm just quickly going to launch a poll. Attendees, if you can just give us an indication from 1 being not valuable at all to 10 being extremely valuable, how did you find today's webinar on medical aid fraud and clawbacks and the role of the regulator or regulators then? I'm going to launch it now. I'm going to let it run for a second or a minute or two. And then perhaps, Dr. Kwinda, I can just ask you for a closing remark.
For me, Lani, is just to say to our practitioners registered with us, we have seen a need to be a regulator that guides the professionals. And the council has invested a lot in that. Of course, that is your annual fees that you pay every year. And we are trying by all means that at least you also see value. Of course, you need to pay the annual fees to remain registered. But we are trying, to bring in value from the regulator by the way we do things. That's why we are committing ourselves to work on, that unit in professional practice to also start handling these matters where you don't feel alone out there. Somebody really wrote there to say, Dr. Kwinda, do you know that there are people who have suffered strokes? There are people who have had, miscarriages because of these clawbacks. And I'm very much aware of colleagues who have had accidents for that matter because of the stress and where they feel like I'm alone, I am by myself and I don't know of anything wrong that I have done. And we hear here the issue of the complications of the coding system, which is open to misinterpretation, and the schemes will interpret them in their interest and so on. That's why as a regulator, we feel that we can't just be a spectator. Let's step into the ground and see how we can be of assistance. And I believe it is going to work as we move along, and practitioners will start to appreciate that. Thank you so much.
Thank you very, very much for that. I've just closed the one polling question. I am going to launch another one. Deon, then I'm going to look in your direction. So the second poll is a very quick yes or no. Would you like to see more of webinars like this? I'm launching it now. Please just give us a quick indication. It's a quick yes or no. Would you like to see more webinars like this? Deon, just before you get a chance to speak, and I'm going to ask you to wrap up for us, take a deep breath. We need to start saying goodbye, but I do just want to engage with everyone attending here today. We had a magnificent response. Thank you so much. We really appreciate you following the EasyMed webinars. Just a reminder that you can register for the next webinar, which is taking place next week, Thursday at 4 o'clock, same time, same place. And we're actually going to talk about efficient healthcare through coordinated systems, or perhaps even a health ecosystem, and how this can reshape the way that we deliver affordable, personalized, and integrated healthcare experiences to patients, and to enable improved health outcomes and even enhance productivity. So it's bound to be a very interesting conversation. We've got our co-founder and global group executive of this BestNet Global Group with us, Hannes van Aswegen, and our very own Deon Buhrs is also joining us. So this is a concept which is mind-boggling, but it's definitely something that we love to unpack, and we hope to have you all there. I'm going to end the poll. Deon, last thoughts from you, please.
Thank you so much. I think Dr. Kwinda's maybe dropped off, but thank you to Dr. Kwinda. Zola, thank you so much for joining us. We walked a long road together as past presidents of the society, and I think we've been quite close to the coalface of the plight of practitioners and these challenging times they're in. I think the summary of it really is, when practitioners are engaging in schemes, there's often a very strong power mismatch or imbalance of power, right from the data that the schemes hold and the approach that they take. And Dr. Kwinda spot on that practitioners feel alienated and alone, and they feel intimidated through the processes. And just having the Health Professions Council there as our regulator to help support and direct and guide us, I think goes a really long way. So we're very encouraged by the intentions that have been put forwards, and we look forward to that rolling forwards. And we'll do what we can do from ProfNet and SpaceNet to support those processes. But we most certainly moving in the right direction, and we thank you guys for that.
Thank you, Deon. Just one last thing from me. Before we started with the webinar, I did ask Dr. Kwinda, is there an email address that providers can use to contact someone at the HPCSA? That email address is professionalpractice, one word, at hpcsa.co.za. I'm just going to repeat that again. It's professionalpractice at hpcsa.co.za. Zola, Dr. Kwinda, Deon, thank you so much. It's been a fascinating conversation, and definitely one that could carry on for at least another hour. We have run out of time. We've run over by 2 minutes. Apologies for that. But attendees, thank you much for joining us again today, and we hope to see you all next week. Take care and look after yourselves and your family. Have a great evening.